Good evening and welcome to session 8 of our 8-session series reviewing physiology for our incoming students at Concord Career Institute to help them get a little bit more familiar with physiology as it pertains to our role as nurses. So without further ado, I will go ahead and we will get started, and I'll share my screen so that we can begin. If you have questions, please feel free to raise your hand and we can talk about things. And if you want to wait till the end, that would be fine as well. Okay, so let's see, here we get started. One more week. This is finishing up, I believe, week 8, then or actually week 9, and then finals are next week, and then break week on the 20th, so that'll be great. So again, as we are following a template and to get some rhythm as to how we go about our review of the different body systems, let's just go back and quickly remind everyone that we have already covered the respiratory system, cardiovascular, nervous, musculoskeletal, endocrine, renal, gastrointestinal, and finally our immune system. And interestingly enough, with COVID-19 being in the news every single day, this seems to be a good one to end with. So let's get started. The systematic approach that we're going to continue with is that we'll touch briefly upon the purpose of the system, discuss how our physiology works normally, along with a couple common labs. We may touch upon some pathophysiology, main nursing implications to consider based on our 4 client needs, some common labs and classifications to start being familiar with, and then finally a few HESI hints as a summary, as a review. So why do we talk about the 4 client needs categories? That's because our NCLEX, the certification or the licensure exam, has all of its questions based upon these particular topics. And so to pass the NCLEX, you need to pass a minimum standard under each of these. So instead of just doing the 4, actually I will do the 4, but we'll also include the subcategories as well. So in number 1, safe and effective care environment, we're going to deal with the management of care and safety and infection control underneath that. Safety, safety, safety. That is like the best, most important thing to recall as you're going through nursing school. The second client needs category is health promotion and maintenance. Do we do a good job with health promotion in the United States today? One might say not so much, but we need to keep working at it, don't we? We need to teach our patients how to take better care of themselves, what small things they can do to promote their health, and how to maintain it. Third, psychosocial integrity. This is a huge piece, and we cannot separate this from our entire physiology, right? Everything that we do impacts our body, mind, and spirit. And I really feel very strongly about that. So you will definitely love term 5 when you get to experience the mental health piece, the psychological component, and how things go awry. But we want to always encourage our patients to have a balanced psychosocial framework as well. And finally, physiologic integrity. And as you can see, there are 4 subcategories there. Basic care and comfort. We want to do the best that we can to maximize our patients' comfort levels. Pharmacological and parenteral therapies. This is where we talk about drugs and injections and IVs and those sorts of things. Reduction of risk potential. Gets back to safety again. And physiologic adaptation. When things go wrong, what does our body do to respond to that to seek homeostasis? So as you're going through each of your chapters in adult health, be it adult health 1 in term 4, adult health 2 in term 5, or adult health 3, which is also known as multi-systems in term 7, each of the chapters that you review has what is called learning outcomes at the beginning of the chapter. And in there's 4 categories, and there will be a variety of outcome objectives. So as you're going through, before you even get started, read through those objectives, the outcomes that they're seeking, so that you know what to focus upon as you're reading through the text. Then at the end of the chapter, review the key concepts, which are in line also with the 4 client needs. The sooner you get familiar with this, the easier in your mind everything will become organized, and you will be able to do well on both your HESI, at your HESI exams as you go through our testing process. And then the goal is to take the NCLEX once and pass, one and done. All right. This, if you've joined me for the other 7 parts of this series, this slide is consistent throughout all of our presentations. And the reason I did this is because I think it's really important that we don't compartmentalize. We start seeing the interconnectedness of all of our body systems, so that it's not just learning about the kidneys and then forgetting about it, learning about the liver, boom, done. Lungs, respiratory, don't need to do that anymore. Adrenal cortex, the adrenal glands, who cares, blah, blah. No, everything is really important, and in any situation, they are all working together to seek homeostasis. So how the body works together to maintain blood pressure, or homeostasis. So we'd like that 120/80 blood pressure. That's that, gold standard. Obviously, things get higher, things get lower, but it's our body systems working together that maintain this homeostasis, that help us maintain homeostasis. So as you can see, if at any point there's a drop in renal perfusion, and by that I mean that there's been a decrease in blood pressure or a decrease in the extracellular fluid, then that will signal to the body, to the kidneys, that, oh my gosh, we've got to secrete the renin, and the liver is going ahead to also secrete the angiotensinogen, which together they're going to go ahead and help to change angiotensin 1 to angiotensin 2 with the help of the lungs, who are secreting angiotensin converting enzyme. So those are the ACE. Remember, for blood pressures, you think of ACE inhibitors. So what the ACE inhibitor does is prevents the conversion of angiotensin 1 to angiotensin 2. All right, so that will, if it's an ACE inhibitor, it vasodilates. The goal of angiotensin, when it changes from angiotensin 1 to angiotensin 2, the goal is to help to vasoconstrict, to increase the blood pressure. If you think about it, of course you want to increase it, because the thing that triggered all this was a decrease in blood pressure, a decrease in renal perfusion. So you're not getting enough fluid throughout the body, and the body's like, whoop, 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 whoop. We need to secrete those hormones to get things, let's go ahead and vasoconstrict, so that whatever fluid we have there will go ahead and be able to maintain a decent blood pressure. In addition to that, the angiotensin 2 tells the adrenal cortex to secrete aldosterone, which tells the kidneys to hold on to sodium, hold on to water. That increases the extracellular fluid, so the volume increases. So together with the vasoconstriction and the retention of the fluids, the extracellular fluid in the vessel wall, in the vessels, that equates to your blood pressure going up. All of this is important, because what is killing people with COVID-19 and with the issues surrounding that is that they're saying that there's problems within the endothelial cells, and that is causing issues where the angiotensin converting enzyme may be having difficulties. And so if it can't do what it needs to do, it can't be released to change angiotensin 1 to angiotensin 2. And if that doesn't happen, you can't maintain a decent blood pressure. So it's all just, to me, very fascinating. I hope you find it equally as interesting, and that we work together to help understand how our bodies create and seek and maintain homeostasis. So again, homeostasis is a relative constancy in the internal environment of the body, naturally maintained by adaptive responses that promote healthy survival. And this is basically accomplished by everything working together in a healthy environment, allowing the ups and downs, the peaks and flows, the peaks and valleys, and also seeking the mean and getting back to balance. We cannot stay healthy if we stay too tightly controlled. We've got to allow for some movement, because it's that movement that helps to trigger our bodies to maintain the homeostasis. So what is the purpose of our immune system? It basically helps to keep us well and healthy in this huge sea of bacteria, viruses, and toxins. It provides protection against invasion of microorganisms from outside the body, and it protects the body from internal threats and maintains the internal environment by removing dead or damaged cells. Please note that inflammation and immunity are critical to maintaining health and preventing disease. So the components, the white blood cells, especially the T lymphocytes and B lymphocytes, but we'll talk about the other pieces as well. What I probably should have written in here is also the lymph system, the lymph fluids, the lymph nodes, what was I going to say? The thymus gland is also important. So all of these things working together, but we typically focus on our white blood cells and how they are stimulated both during innate and adaptive immunity. So from a physiological perspective, the initial response is a non-specific response, and that basically is our skin protection, inflammation, and phagocytosis, meaning that the cells, the white blood cells, are eating and defending against these uncertain invaders. If that doesn't work and there's something that persists, the more specific response of acquired immunity is triggered. And in that, we'll talk about both natural and artificial components of that system. White blood cells, we need to also touch upon that, and we will do so. There's a variety of different white blood cells, the neutrophils, which are part of the innate system, and the other major part that's part of the more specific response, the acquired immunity, are the lymphocytes. And we'll talk about that, and I found a fabulous video from Khan Academy that I'm dropping into the chat so that you guys can actually see that as well. But all of these things working together keeps our bodies healthy. So the common pathophysiology, when things don't work well, we develop infections. If things are hyperstimulated, autoimmune diseases are created. If you have a transplant, there may be transplant reactions if our immune system is not properly silenced. And then even with all of that going on, some people are just hyper responsive to foods or to bee stings, and they might have anaphylaxis. So we'll talk a little bit more about these things as we touch upon the nursing implications and the medication classifications towards the end of this presentation. So during, as we review our client needs for the immune system, I chose in chapter 17 of our medical or adult health text to use the question or the focus point that we needed to interpret laboratory findings, and I believe this is under the physiological integrity section, number 4, interpret laboratory findings to assess the patient's risk for an immunity problem. And you can find this on page 289. I'm going to pull that up so that I have it handy as well. And that is indeed under physiologic integrity. And for this particular chapter, it's interesting to note that the only two that are addressed here are health promotion and maintenance, number 2, and physiologic integrity. So there's not something listed under each of the 4 client needs for this particular body system. So again, how do we interpret our lab findings? Well, we're going to look at, since the major component of our immune system is the white blood cells, we're going to look at the white blood cell count to determine the patient's risk for infection and the presence or absence of infection. And by doing that, we look at their total number of white blood cells. And if it's more than 10,500 with a shift to the left, then we think that there might be an infection, a bacterial infection. If indeed there's a increase in the number of eosinophils, that would signal an allergic or parasitic infection. And when the segmented neutrophils themselves, like as a subcategory, are increased to more than 6,200, we think that it's bacterial. And if the lymphocytes are increased, oftentimes it is viral in nature. So please note those, that little bit that I just shared with you can be found in summary form on page 303 in our adult health textbook. And also that lab values, as we've talked about before, will vary with each facility and lab, but the general ballpark of the numbers will remain the same. And white blood cells are where we're going to be looking. And white blood cells are known as leukocytes. Leuko meaning white, cyte meaning cells. So when we're talking about immunity and protection from illness or disease, in a prior edition of our adult health book, they had this picture in which there was a moat and a castle. And the first line of defense was the moat, or that area around the castle. And basically what it did was slow down the approach of any invaders. So the moat is filled with water around the castle scenario, but in our bodies, what we have is normal flora, the good bacteria and stuff on our skin, along with the barriers on our skin and our mucous membranes that are intact, and that helps to prevent slows down any invaders from getting in. The second line of defense is the castle wall, the watchers, and the alarms. And basically, if that's functioning well, any invaders are reduced in number because of the inflammatory response, which we will learn is also known as the innate response. And that happens just really immediately. If something breaches the system, then boop, 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 boop. We don't know specifically what's going on, but we know there's a problem, and the complement is released. It's an inflammatory response and starts to trigger the notification of the third line of defense, the strongest knights and soldiers in the castles, also known as the white blood cells, the leukocytes, to come to the aid and defense of the body. And this is where the leukocytes can capture and kill the invaders instead of just like circling them and getting to the surface to defend against them. They'll actually start killing them, and the specific immunity will also be developed. So things do somewhat overlap just a little bit, but we want to have intact skin with our normal flora on our skin, because that helps to keep down the bacteria and viruses that might be on our skin surface. That's always my concern. If we wash our hands too terribly much, we might be actually removing some of our protective normal flora, which is critical for that to act as that first line of defense against infection. So just be aware that with everything that we do, there's a positive and a negative potential outcome from that. Yes, we do need to wash our hands and be religious about that, but washing with soap and water will be better than necessarily always using bactericidal things that are killing the good bacteria on our skin. I also suggest that you read over chapter 2 in our Med-Surg book, because our adult health book, that covers some of our basic concepts as well. Okay, for immunity at least. So leukocytes, the white blood cell defensive actions, they have a lot of things that are going on in the body. They act to recognize self versus non-self. We're not going to dig too deeply into that. We'll cover that more in, I believe, term 4 and term 5. But it's important that our body knows what's us and what's not us. And it will, defend against the non-self, but it should not trigger the immune system to fight against the self. If it does do that, then of course that would be somewhat of an autoimmune problem, correct? The leukocytes' role is to destroy the foreign invaders, to remove the debris and unhealthy or abnormal self cells. So when our body cells die off, which they normally do, our immune system and our white blood cells remove those. They also act to produce the antibodies, the B cells, against invaders, and I will share the video at the end. When we talk about complement activation, when it's released, the complement enhances the cell actions of innate immunity. So this is something that's triggered early on for the purposes of inflammatory response, and it complements or augments our immune response. And then finally, one of the other things that the leukocytes are responsible for is the production of cytokines that stimulate an increased formation of white blood cells in bone marrow. So how does this all tie into our COVID-19 pandemic deaths? Let's see, that was the YouTube, and I also have an article that talks about, it's entitled Complement in Immune and Inflammatory Disorders, Pathophysiological Mechanisms. I may post it here or I may save it for a later lecture, but you can Google that as well. And it's a 2014 article by Daniel Ricklin and John Lambris. Okay, so the cytokines, when they're released and they work normally, it's not an excessive situation. But when there is what's known as a cytokine storm, things are hyperstimulated, and that seems to be what is the bottom line of the hyperstimulation of the immune system in many of these patients who don't do well as a result of their COVID-19 infection. So the majority of the severe cases and deaths from COVID-19 are a result of this runaway inflammatory response within their immune system, causing the cytokine storm that is difficult to interpret. We're constantly learning more and more about this. Probably by the time you finish this term, there'll be even more information that we will need to know. And later on in this presentation, I have some other articles that I think are interesting and you'll find helpful. But we'll just walk through this step by step, okay? So the normal immune response is triggered. Okay, that happens. When that happens, the innate system kicks in and the macrophages and the dendritic cells release cytokine signals. This tells the inflammatory reaction to kick into gear, and then the lymphocytes start getting activated as well, not just the macrophages, and they'll start destroying the COVID cells. The thing with that is the COVID cells apparently are releasing these inflammatory markers. And so what happens then is that the lymphocytes that are involved with trying to fight against them are damaged while trying to destroy the COVID cells. These damaged lymphocytes release even more cytokines. So everything is releasing inflammatory markers and cytokines. And so there's this hyperstimulation, there's this release of all of these stimulants from either the lymphocytes that are damaged or the COVID-19 cells themselves are producing the inflammatory markers. The immune system is just stimulated out of control. So instead of being here in the middle where there's a homeostatic kind of thing, it's pegged all the way to the red side, hyperstimulated. This inflammatory reaction continues to increase, and as a result, it begins to damage even healthy cells, leading to acute lung damage. So anything that is done in excess can just run amok and start destroying perfectly good cells. So this is an example of when good intentions run amok. And it's sort of like the negative feedback system has been shut off and the immune system is in overdrive. So we have to try to figure this out. So that's how it all works is working these days with the COVID-19 infections. But let's back it up just a little bit and talk about basic inflammation, which is also known today as our innate native ability. So this is what we're born with. It is our first process against necessary for our human protection. We'll talk about the other two types shortly, and those are the antibody-mediated immunity, which is from the B lymphocytes, and then the cell-mediated immunity from the T lymphocytes. But before we get to that, we'll talk more about just inflammation. It's so critically important in the natural protection of each of us. It's an immediate response against effects of tissue injury and foreign proteins. So if you hit your leg, then you're going to stimulate your immune system to get the inflammatory process going. And so any sort of tissue damage, whether it's from an invading organism or from trauma, can trigger this. It cannot be transferred from person to person and is not an adaptive response. So inflammation in and of itself is part of our innate native immunity. As I mentioned, this differs from the antibody-mediated immunity and cell-mediated. Our inflammatory protection is immediate and short-lived and does not provide protection if we're re-exposed. Inflammation is nonspecific and can be triggered by almost any event. Okay? And that can be either tissue injury or organisms. As you may recall, the 5 cardinal manifestations of inflammation are warmth, redness, swelling, pain, and decreased function. So just think about hitting your leg accidentally when you are playing sports. So obviously what happens? You get a red, warm, swollen area. It hurts, and you don't want to move that extremity as much. And so what do? We use RICE, rest, ice, compression, and elevation. And that helps with a traumatic injury to an extremity, which helps to silence our inflammatory response. I found this slide extremely helpful to help differentiate between innate versus adaptive. As we recall, the innate immunity is basically inflammation. That's the part that happens immediately from any trigger. Does not mean that you've got an infection of any sort. It just means that there's something that is abnormal, that the body wants to get its troops ready and to the site to see what's going on. And with this, you'll see an activation of complement. The macrophages will be mobilized, these dendritic cells, the mast cells, which are part of the immune response that helps to crunch up phagocytosis. They grab a hold of whatever the organism or the offending substance is, and it just is put into the cell. It's engulfed into there, and the body's protected. The other white blood cells that are involved in this are the neutrophils, the eosinophils, and basophils, which are all, if you had to group them together, they're called granulocytes. And why are they called granulocytes? Because if you look at them when they're stained, they have these little granules. See all the little dots? So they look a little different, but they all have those granules. So they're called granulocytes. All right. That is all responsible for the innate immunity. You notice that there's a type of white blood cell that's not listed here, and those are the lymphocytes. And specifically, it's the T lymphocytes that are activated that have to do with the cell-mediated response. The B cells, and there's B lymphocytes as well, those also produce, the B cells are the types of lymphocytes. See, they look the same? T cells or B cells. They are all, if you're going to group them as to a type of white blood cell, they are lymphocytes, okay? They look the same, lymphocyte, lymphocyte, lymphocyte. The B lymphocytes produce antibodies. Remember, B cell, anti-B bodies, okay? T cells produced in, I believe, the thymus, and they have to do with the CD4, the T cell count. And what do you know about the T cell count? What disease process do we track T cell counts? If you said HIV, you would be correct. All right, so the key difference between innate and adaptive immunity is that innate is fast immune response that provides the first line of immunological defense against infections, while adaptive immunity, the second part, is slower and is mediated by T and B lymphocytes. However, or moreover, the innate immunity is present at birth, while the adaptive immunity develops after exposure to a specific antigen. So if we're exposed to COVID-19, for example, we would be having these B lymphocytes and T lymphocytes stimulated to hopefully be able to either produce antibodies against it or to further engulf them before it even gets to that, because we are going to have some innate immunity that happens as well. But with all of that, we're going to be trying to destroy the antigen, meaning the virus, and also to promote or produce the antibodies against it. So what's the difference between infection and inflammation? Infection is actually, by definition, the invasion, not only the invasion, but the multiplication of those microorganisms in the body tissues, as in an infectious disease, like otitis media, ear infection, appendicitis, right lower quadrant pain in our intestines, and then viral hepatitis are good examples. So those would be infections. It's usually accompanied by inflammation. However, inflammation, also part of known as our innate immunity, can occur without infection. In my mind, I think that if I'm exposed to anything, I would like to think that my immune system, my innate immunity, is going to kill it. It's going to bring forth the folks, the macrophages that are going to destroy it, so that I don't have to get the lymphocytes stimulated with the adaptive immunity to fight against it. So if we can take care of it at the lowest level, then hopefully we do not get an infection. So what are some examples of inflammation that occurs without infection? And as you can see here, spraining your joint, actually a heart attack creates the inflammatory cascade as well, or blisters. So there's no infection in any of those things, but the inflammatory response has been initiated. Other examples would be allergic rhinitis or contact dermatitis that's non-infectious. So inflammation does not always mean infection is present. It just means that our body's doing what it needs to do. When we start comparing and contrasting the innate versus adaptive immunity, we're looking at adaptive immunity on this slide. So to separate it, innate immunity was the inflammatory response that is non-specific. Adaptive immunity is specific. So it has to be exposed, your body has to be exposed to some sort of antigen to trigger this. And the way that our body responds has to do with whether it's naturally acquired or artificially acquired. If it's naturally acquired, it means that no outside interference or additions have been added to our human body. It's all you're working upon just using what's within our human body, naturally acquired. So let's talk about that first, naturally acquired. So if you're exposed to a germ and you get sick or don't get sick, you might just kill it, right? And produce the antibodies. So when the antigen, let's say it's COVID-19, enters the body naturally, the body induces antibodies and specialized lymphocytes to fight against it. That would be an naturally acquired active response. How is that compared to passive response? Passive basically means that the human body is receiving the antibodies passively from someplace else. So since we're dealing just within the human body, can you think of a time when a small person, and I'll give you that hint, a small person would get immunity from another person passively? And the classic example is when antibodies pass from mom to the fetus via the placenta or to the infant via mother's milk. And as I mentioned in the medical terminology lecture this evening, I'm not certain about the transmissibility of the antibodies in response against COVID-19, but that might be fun to research for a future time to discuss. Okay, so we've got that immunity. We've either created the immune response ourselves, meaning we got the infection as adults or children, and we produced our own antibodies and lymphocytes actively. Or as a new baby or a breastfeeding baby, we got antibodies naturally produced from the human directly, passively to the baby. How is that different from artificially acquired? Artificially acquired simply means that it's coming to us to our human body as a form of injection. So artificially acquired, it's coming from outside of our own human body. It's coming via an injection. And how does that play out? Where do vaccines fit in? So let's just keep it to the COVID-19 piece. So to get artificially acquired active immunity, the inactivated virus would be introduced in a vaccine, and then our body produces the antibodies and lymphocytes against the antigen. In this case, it would be against COVID-19. If we get a vaccine for it, it's considered active artificially acquired immunity. If we, on the other hand, get the antibodies themselves that have been produced in another person, because folks, when they donate blood, can see if they've got antibodies. Many of the blood donation locations are doing this. They check for antibodies against COVID-19, then they can be processed and then be used to be injected into or infused into other people who may be ill with COVID-19, and they would be then receiving the pre-formed antibodies in an immune serum that would be given via IV injection, typically IV injection. Well, let's just say any injection. For COVID-19, I believe that they're doing IV infusions. Another example would be for treatment or prevention of rabies. If indeed you've been bitten by a rabid bat or a raccoon or something like that, then you would get injections with the antibodies that would fight against the rabies, and that would be considered artificially acquired passive immunity. All right, so I hope that helps just a little bit to distinguish the different types. Bottom line, vaccines, if you're getting a vaccine and your body still has to produce the antibodies against the infection, it is still that's considered artificially acquired active immunity. So a vaccine still requires you to have an intact immune system so that you can then produce the necessary antibodies from your B cells, B lymphocytes, because that's where antibodies are produced. This slide may be more than what you need at this point, but I found that it was interesting, and we'll just skim through it just a little bit because it talks specifically about COVID-19 and the pathophysiology of hemostasis disorders in critically ill patients with COVID-19. And this was an article by Jolie, J-O-L-Y, Siguret, S-I-G-U-R-E-T, and a last name that starts with a B that I cannot pronounce, but it's a 2020 article. And I'll be happy to provide it for you if you're interested. It was, I love these sorts of flow charts that help to track how things actually happen. So the SARS or COVID-2 infection, but the reason it's actually COVID-19 in that was the year that it was identified. COVID-2 is just a type, but it basically all triggers the same thing. ACE, angiotensin converting enzyme 2. Remember that happens, where does that happen? Oftentimes in the lungs, right? Remember from that first, the first earlier picture that I showed back at the beginning, but the host cells are present in vessels, lungs, hearts, kidneys, GI tract, and the biliary tract. So when this ACE2 is released, then there are receptors that are present in all of those places within the body. And we talked about how the cytokine storm happens, and it's basically this excessive immune response, and all of these things just start getting hyperstimulated. We don't have to go into the meaning of all of these different things, other than the fact that the interleukins, IL, that's what IL stands for, interleukin 1, 2, and 6, they all get stimulated. Macrophage activation syndrome happens later on. Let's see, where is that? MAS? Don't know. I thought it was here. Okay, I take it back. So if you see that acronym, macrophage activation syndrome, that's another thing that happens, which basically says that the macrophages, which is part of our innate immune system, gets activated, and all of this starts happening not just in a normal way, but for some reason it becomes hyperstimulated. So when anything is hyperstimulated, it just goes from being protective to almost attacking, is basically the best way to explain it. So with the excessive immune response, the local and systemic inflammatory response happens, SIRS, right? You'll get hypercoagulability. Basically, you'll start coagulating in places you're not supposed to coagulate. And there's endotheliopathy, which basically means that the lining of the blood vessels are like acting inappropriately. And so there'll be vasoconstriction, become more procoagulant. And so as a result, just think about if the vein or the vessels are constricting and the blood is coagulating more than usual, what does that equate to in your mind? Yeah, certainly the creation of thrombus, right? The blood clots, that can happen. And it can be either big, macro thrombus, venous and arterial, or micro. And basically when it happens, teeny tiny ones, you'll end up getting those in different parts of organs, and you'll have multi-organ failure. And so you go from a respiratory disease to where the inflammatory response is hyperstimulated. It creates the endotheliopathy and hypercoagulability. So everything gets narrow and thick. The blood gets thick. You start having a decrease in blood flow, hypoxia, all of those things start falling in together, and pulmonary emboli and acute respiratory distress syndrome, all of those things start happening as a result, not specifically of injury directly to the lungs themselves solely, but throughout the whole body, based on this endotheliopathy and hypercoagulability as a result of hyperstimulation or hyperresponse of the immune system. So when the immune system works well, it protects us. When it gets hyperstimulated, it becomes a problem. So looking at some basic things that can happen as far as common problems within the immune system, we've talked about a lot of COVID-19, but let's talk about things that happen more commonly to where a patient might present, not just with COVID-19 as shortness of breath, but, or it could be COVID-19, it could be whatever, shortness of breath. So the nursing diagnosis that goes along with that is ineffective airway clearance. And that can happen from the problems that we saw previously with the hypercoagulability and all of that, which is a different pathway. It can also happen more commonly with bronchial spasms and laryngeal edema, swelling. What does that sound like in reference to the immune system? has a lot to do with, say, an anaphylactic reaction, or the bronchial spasm could be from asthma. It could be a trigger from a immune response, a sensitivity reaction to a toxin or smoke, which stimulates the immune system and can cause the bronchial spasms as well. And the medication that often is used is epinephrine, Benadryl, also known as diphenhydramine, albuterol to dilate those bronchioles, and steroids to help suppress the immune system. If you have a cough, you may get codeine to silence the cough at night. Other things to thin it down. If it's a productive cough and you've got a lot of sputum, you may get guaifenesin to help liquefy it. So with that, does that necessarily mean that you have an infection? No, it doesn't. However, you can also have infection as the cause of shortness of breath. And that can come from germs or even aspiration. If you aspirate some food or tube feedings from like an NG tube or anything like that, you can go ahead and get aspiration pneumonia, and we'll need antibacterials, antibiotics, or antivirals to help take care of the problem. So a common antibiotic is azithromycin, also known as a Z-Pak, and a common antiviral would be known as acyclovir. Curious why we haven't been trying acyclovir with COVID-19. I don't know. I mean, there's a lot of different antivirals. So as we've talked about before, if you've been with me during the other presentations, I encourage you to take each of the meds that were listed on the prior slide and create a medication sheet or card for each of those, also including their drug classification. So start, as I've mentioned before, with drug classes, and then if you learn the drug classifications, there's often multiple drugs underneath each drug classification. So if you can learn one drug class, which includes 5 to 10 meds, don't you think it's easier to learn one thing versus 5 or 10? So always put your classification, learn via the classifications, and then identify the specific meds within each classification. And you'll get more of that in pharmacology, but I just wanted to start touching upon that so that you had a brief introduction and to reinforce the fact that it all fits together. And we're going to be putting pharmacology and pathophys, weaving that all throughout each of our adult health courses. Okay? And like I mentioned, if you already have drug cards for all of these, if you've already taken pharmacology, fabulous. Be sure that you have drug cards for each of the 24 or 25 that we've covered during this physiology review, and then keep building on them. And I found this slide from an article that was a NIH article that I found a couple months ago, and then I liked the summary diagram picture. So I'm just going to read through this, okay? And we're going to talk about how these things, and I think it's really good to have a depiction of things that we've talked about already. So in this first section, the body is triggered directly by foreign and altered substances, and the complement network resides upstream of most defensive and homeostatic systems, therefore acting as an important mediator of the physiologic and pathophysiological processes. So what does this all mean? So anytime that there's a foreign invader, materials, immune stimulation, trauma, any of that, you'll go ahead. DAMP means damage associated molecular pattern. PAMP is a pathogen associated response, and then surface triggers just happen as a result of being like traumatized. How does all that play out? What was I going to tell you? TLR. Had all of my, toll-like receptors. I went ahead and put all the abbreviations for all of these things off to the side so it'd be easier to find. But as we talked about before, whenever the innate immune system is stimulated, complement is released, right? And when the complement's released, it's like sending out notification to all sorts of things. So the polymorphonuclear cells, this is also known as white blood cells, right? T cells, TLR, toll-like receptors, all over the place. We've got all of these different organisms or different parts of our immune system being triggered. And you can see what happens at the end of all of it is the cytokines are released. We talked about the cytokine storm, trying to beef things up. Phagocytosis, the cells start engulfing the organisms, and the adaptive immunity is stimulated. Remember the B cells, B lymphocytes, those are the ones that create the antibodies. The complement increases the coagulation, which we talked about with the COVID-19, how the endothelial damage and the hypercoagulability. So all of these things are happening as a result of the immune system being stimulated. So the second portion of this, while it talks about the complement-mediated immune surveillance and usually provides a decent physiological response, and this is the green arrows. So with a normal cell, they basically, if normal cells are, self-regulated, they know when their lifespan is over, and they just say, all right, apoptosis, I'm going to die, I'm dead. And so the normal cell will just do that. If that doesn't happen, then what will happen is the immune system will help to take over, and they will go ahead and sometimes there's in a self-attack, danger signaling, inflammation, and lysis. And some examples of that happening are atypical hemolytic uremic syndrome, which is not seen, but you get red blood cells that will start breaking up and increase urea in your renal system. DDD is dense deposit disease. These are some things I've really never even heard of. And paroxysmal nocturnal hemoglobinuria. You'll see some weird nighttime hemoglobin in your urine. So these are some things that can be examples of when the system has gone somewhat awry, but not to the extent that it's causing, significant disease. If there's this continues and other things get stimulated, you can have the apoptic cell debris. So when the cells die automatically, apoptosis, they know it's the end of their life cycle, there's going to be some debris that collects, and it can start triggering, according to this particular diagram, an autoimmune response. And systemic lupus is an autoimmune response. AD is considered Alzheimer's disease. So isn't that interesting? That might be part of the accelerated aging process. And AMD is age-related macular degeneration. So it's interesting how these disease processes are the result of the immune system either working or not working in a normal fashion, but in a disease-related fashion, which would be, of course, the red zone, the red area. When microbes get in the body, if our body is doing a good job, then it will eliminate the invading organism and send out the complement and tell the rest of the body that there's danger and raise the warning flags. If the body cannot fight against it, then you may get bacteremia, meaning bacteria in your bloodstream, and that can lead to sepsis. In a transplant situation, if properly medicated, the patient does fine. They can accommodate the transplanted organ, but if the immune system is hyperstimulated, it may reject it, and the organ and cell may have a transplantation reaction. And then biomaterials, other different things that we put into the body for healing. Like I think a good example would be a hemodialysis, fistulas and such. If the body senses that as being not really invasive, they can tolerate it. But if they see it as super foreign, there could be a hyperstimulation of the immune system, and there could be problems with the dialysis implantations that are being used. So I think this was just a fun way to look at a variety of different ways in which our immune system is triggered, either in an effective way or an ineffective way. And as our final slide, we're going to reflect a little bit through our HESI book and talk about just a little bit about anaphylaxis and how we need to think about things that might cause anaphylaxis that we may not be familiar with. So some people have terrible symptoms of anaphylaxis as a result of a latex allergy. So this is caused by reaction to the proteins in natural rubber latex or the chemicals used in making latex gloves. Fortunately, today we don't have a whole lot of those, but anything can trigger. It could be latex or not, or a bee sting, or any of these things. But the symptoms of the anaphylaxis could still occur. And typically, we're talking about trouble breathing, shortness of breath, wheezing, coughing, throat tightening, facial swelling, hives, redness especially to the chest and the itching, nausea, vomiting, abdominal cramps, dizziness, lightheadedness, fainting, any sudden changes in behavior or irritability. So those are some common signs and symptoms of anaphylaxis. If it's moderately severe, like the symptoms may be mild, and it could just be hives. I would not, if it's just contact dermatitis or contact stuff, it would not, in my opinion, be considered anaphylaxis. That's a life-threatening thing. But if it's mild, you can treat it locally. If it's moderately severe, that could be rhinitis, runny eyes and noses, conjunctivitis, urticaria, the itching, or bronchospasms. And the severe life-threatening anaphylaxis is associated with airway compromise, and they'll need epinephrine and oxygen to help to help reverse the anaphylaxis. So the epi will go ahead and fix the anaphylaxis, and the oxygen will get the oxygenation to the hypoxic cells of the body. One of the things I think is important is to also know that there are common food allergies that people may have that they don't realize they also have latex allergies. So I'll read through these because I've known some students who have these allergies who didn't even realize that they might have latex allergies, and then got a hold of latex gloves somehow and had topical reactions. So you may, like I said, have just contact dermatitis from the gloves versus a true anaphylaxis. But kiwis, bananas, pineapples, tropical fruits in general, so that sort of covers those, grapes, avocados, potatoes, hazelnuts, and water chestnuts. So if you happen to be allergic to any of those particular things, or you have patients who are allergic to those, be aware that they may also have cross-sensitivity to latex. So their immune system may get hyperstimulated and cause an anaphylactic reaction if they happen to be exposed to the latex. So these HESI hints are found in our green NCLEX book, pages 966 through 969. Go back and review that as well. And I hope that you found this interesting. Keep up to date with the COVID-19 data. I know that Florida today is the 9th of July. I know our numbers are increasing. My hope is that we create herd immunity soon, meaning that we have enough people asymptomatic or who have recovered that have the antibodies that will help to control the infection. So that concludes our lecture for this evening. That concludes our series. I hope you've enjoyed it, and I look forward to hearing from you for any questions or concerns or other things that you might like to have covered. Again, my email is levers, E-V-E-R-S. So Lisa Evers, E-V-E-R-S, at Concord, CONCORDE.edu. Thanks again and have a wonderful evening. All right, go ahead and secure our recording, and that finishes up for this evening. Have a great weekend. Good night.